I will present here a new technique of an arthroscopic reconstruction of 2 to 4 parts fracture of the proximal humerus. This technique I have been using since 2011, and since then about 90% of all fractures are done with this technique. It is mainly used for 3 parts fractures, including the greater tuberosity or head and lesser tuberosity, or in some cases of the 4-part fractures with a surgical neck fracture and less displacement. This technique is based on correcting the angle of displacement of the head and bringing the 2 tuberosities together. First, we have to assess the fracture. Is it with valgus angulation of the head or a varus angulation of the head? The instrument we use the giant needle with a special suture, and a new device, we call it the giant suture wire, which is composed of a wire and a suture added to it, a guide, and we use for that also K-wire, of course. The setting is by having the C-arm imager and the arthroscope simultaneously, and we work by looking at these 2 monitors. Now, this case of valgus head angulation, we have first to correct the angulation and then fix it with K-wires. In case of varus angulation, we slight abduct the arm, abduct the upper arm, and then fix the head to the shaft. It will be the first step to be done. And we go with the K-wire about 12 centimeters below the fracture, under imager and through the 2 fragments. It's like the precutaneous fixation, and we can use here 2, 3, or even 4 wires to make this fixation. Of course, this is done also under arthroscopic and C imager. Now, after that, after we fix the head to the shaft, we have 2 parts or 3 parts fracture. We use the giant needle to pass to adapt the 2 tuberosities together. First by passing suture through the subscapularis, and then suture through the infraspinatus and part of the supraspinatus. Then we pull the lower end of the suture through the portal, arthroscopic portal outside, and make a knot and push it inside. Then we pull the upper end of the sutures and tie the 2 fragments, so we have a really good compression of the 2 fragments by using this technique. So we have now the 2 fragments together, it's on 1 fragment. We have the head fixed to the humerus. Now, after that, we go back to our K-wires. We bring the guide and put it on the K-wire, and remove the guide and push the so-called giant suture wire through the same portal to get it inside the joint, and pull the suture from the joint with the so-called chop needle, which goes through the tendon, and pull the wire outside. Then the lower end will be pulled up through the instrumentation portal, and we tie the fragments together. And this can be repeated once or twice. Here we see the X-ray showing the fixation of the head to the shaft, and here by passing the giant needle through the tendon and then make reconstruction here. Before, we see the greater tuberosity is displaced markedly, the head is tilted, and after that we have the head approximately in a good normal position and the greater tuberosity reconstructed in its place. Post-operative, we immobilize the shoulder for 3 to 4 weeks, then start rehabilitation. In a period of 6 years, we did about 33 cases. We were able to review 28 cases from them, and their average age was 6 years, and the average follow-up was 2.5 years. Most of the cases were 3 parts fracture, about 54%. The rotator cuff tear was involved in 14%, and more than 60% of the patient had osteoporosis. So we used the giant needle and the giant suture wire in most of the cases together. So, and after that we had a radiological assessment of all the cases, and the results were excellent results in the 2-part fracture, and in about half of the 3 parts fracture, and about 30% of the 4-part fractures. All fractures were united, and in 30% there was a malunion of the 4-part fractures. So in conclusion, there is no disturbance of the blood supply using this technique. The patient goes home on the same day or the next day, and the old people, they would like to do this surgery because they don't like to do open surgery for morbidity, and the age as well as osteoporosis is not an contraindication in this procedure compared to other procedures. There was no complication of osteonecrosis or non-union. Thank you very much for your attention.